Andre and Matthias. I don't want to interrupt you, but you are live. It's great.
Thank you. Okay, very good. Can you hear us?
Absolutely, yes.
Fine, okay. Okay, yeah, we right away start with our case. Maybe Matthias, yeah, can you?
Of course, yes. So we have occlusion of the posterior tibial artery, cranial limb ischemia. Next slide. Forefoot ulceration right side, rest pain, ABI very low, 0.3. He had a femoral popliteal bypass on the right side. The deep femoral artery right side is occluded. However, the bypass is running down very well. It's open. And she had also on the left side some interventions. Next slide. This shows you the angiogram. So this is the distal portion where the anastomosis of the P1 bypass ends up. Then the popliteal segment is open. However, the posterior tibial is the main artery reaching down to the foot, and it's occluded in the proximal segment. We want to treat this now. Yeah. Next slide. We are in a crossover approach. Because of the bypass, we changed our strategy. We don't want to stress these anastomosis and the bypass too much. That's why we are crossover approach with a long sheath. In case we cannot open in an antegrade way, we also perform foregoing retrograde puncture of the distal posterior tibial artery, and we want to use the DCB. And maybe TEX if necessary.
Yeah, if necessary. Yeah, thank you very much. So maybe we can switch to the angio screen. Of course, usually for below the knee lesions, we go directly antegrade down, so ipsilateral. Or in this case, with several bypass reocclusions, we actually didn't really want to puncture that bypass, especially also he has no profunda on the right side. Sorry, no images here. So we choose here the crossover approach, knowing that we have to go retrograde at the foot anyway. Also here, not so easy. He has a common femoral artery occlusion, actually, where we had to puncture through the occlusion, also some external disease. But sheath then finally reached down here. It's a 6-French 90-centimeter sheath. And you can see here, it looks a little worse maybe than before with an occlusion of the trunk. Peronal open, clearly no stump indicating where the posterior will go down. Some calcium at the trunk, but not really. So now that was contralateral. This is a little bit ipsilateral to open up the angulation between peronal and posterior, but also here, not really calcium visible to tell us actually where to go. Yeah, and sorry, we tried also a little bit already to get here into the posterior. But first, let me show you once again here the outflow at the foot. Truly, the posterior is the main artery. And here, as you can see, yeah, we tried already here to find an entrance. No, it doesn't. No, okay. No. This looked like, but at the end, it was also stuck, and finally wire always went in one of the collaterals, not even actually currently into the peronal artery. So we punctured already here now. So also here just collaterals, but not really something to help us. We punctured already the posterior tibial artery, did it with ultrasound, I think. Yeah, also for us, ultrasound for the superficial arteries is standard now. Maybe you can switch quickly to the ultrasound, or I don't know. Yeah, just briefly, sorry, not the best images, a little bit to the right side. So puncturing of the posterior tibial artery in transversal section. Needle goes into the artery or through the artery. And to get the wire in, you go longitudinally. Maybe next film shows you. Next, please. Ollie? Yeah. Yeah. 9, yeah. Okay, yeah, the wire here now entering the posterior tibial artery, very nice. I think very important to have a echogenic wire, otherwise if you do it with polymer-coated wire, which we usually use for angiographic puncturing, it's very difficult to see these wires. Okay, we are in and ready to go retrograde now. up the posterior tibial artery.
Do you intend to
Yes.
use
And,
an introducer
after that-
or a support catheter?
Yeah, actually we have now an introducer here directly in the sheath. Maybe Matthias, you can. It's the CXI catheter, which fits nicely here through that sheath. I can push it for you.
Andre, it's Rob Luckstein. Which guide wire are you using here for your retrograde recanalization?
Yeah, it's the old PT2 guide wire. Of course, I mean, once this fades, we may take another one, but this is still our workhorse to start with. Not necessarily, nitinol wires, but just this low tip load 014 wires. Yeah, not 018 to start with. Okay, I hold the catheter here, maybe.
I drill
So
a
it's
little bit.
approaching here the calcium. Okay, very nice.
No,
Yeah.
it's super easy now.
Super easy. Stop here and let's snare. Just a moment. This is a Judkins right overlength catheter. Oops, just a moment. I twist the catheter a little more to the like here. No. Other side. Just a moment, Matthias. I don't think so. Shall I take it to that side here?
Okay.
Yeah, here it's touching, and by pulling back a little bit while twisting the wire, should actually jump in.
Yeah.
No?
Right. Yeah.
Yeah. Okay. Yeah. Okay.
Very nice.
Yeah. To make it more, make it more stable, maybe you can push also the support catheter here into the Judkins. Yeah.
Okay. Now it's very easy to advance the wire. Okay. I think you can pull.
Yeah, we thought here to take a scoring balloon down
Should be out. It's
to
completely.
pre-dilate. We have an angiosculpt balloon, 2.5. I don't think is too big.
I remove the
2.5.
catheter.
Yes.
Can you hold the wire?
100 millimeter long. They sometimes have a profile which is a little bit difficult to bring into tibial arteries, but of course with a pull-through wire, that should help us to bring it down.
I do this for you, Andre.
Which wire will you use to integrate? A more supportive 014 wire, Andre? What, now that you put your catheter down, integrate?
Yeah, actually, in this kind of lesions, we actually really do not see any stump. So I'm not sure whether really a CTO wire helps. Otherwise, of course, for difficult lesions, we take CTO wires. But maybe not in this case. I don't know. Would you have escalated with your wires from antegrade a little bit? Poking around in no man's land where you don't know where to poke to, I think is a little difficult maybe.
No, I think that was a beautiful example of how something's very difficult to wire integrate with all those little collaterals and how easy it was retrograde.
Yeah. Du hast einen Poker? So now the angiosculpt balloon is stuck here. And now, let me nicht ziehen. Okay, du ziehst.
Okay.
Yeah.
Du stoppst.
Now we clamp the wire at the distal end or the proximal end of the balloon. Matthias is now pulling the balloon inside hard.
Yeah, but
Not so easy.
But should be enough, huh?
Of course, you could also pre-dilate.
Yeah. Maybe
Shall
it's
we
enough.
a little
Huh?
more? A little more?
Shall I pull more?
No.
Okay.
Okay, more?
Shall I pull more?
I think we're in an open segment and
Yeah.
we can easily pull out the wire now. Kannst du ihn deblocken? Den Dart?
How long is that balloon that you're using?
100 millimeter. Yeah. Can you pull wire out?
Of course, yes.
And are you going to use this to
we
go
can
all the way
already
back
pass
into the
here,
tibial
maybe.
peroneal trunk?
Yes, we plan to do this, yeah. Of course, now this will take some time. Just a moment. So tip of the scoring balloon in the sheath, maybe.
Yeah.
So therefore, I cannot really aspirate blood here, but now there's some blood coming. I can inject here a little bit. We may see, of course, here now
The
a
occlusion.
lot of spasm. I will take the wire down now from antegrade and pass the sheath.
Maybe in the meanwhile, we can also remove the sheath and compress when we go in for
Yeah.
PTA.
Let me first
Yeah,
bring
yeah.
the wire down, just a moment. Can you pull maybe the sheath already a little bit? Just a moment.
So
Wire
is
contact
this
here.
the same wire going down antegrade, PT2?
Yeah, yes, correct. So we just reversed wire direction. And can you pull sheath a little bit? More. Yeah, I guess there's a
maybe
lot
we
of
just have to pull it out.
a lot of
Sometimes.
spasm, even more, I think. Just pull more.
It's not far in anymore.
No, I think you have to pull a little more. It doesn't matter if it drops out.
Okay.
I mean, of course, we can also save this step for later. Du musst noch mehr ziehen, Matthias, so geht das nicht. Noch. Doesn't necessarily go here into the artery now. We can wait until spasm is over. What do you think?
I agree.
Yeah,
Matthias?
I would remove the sheath.
Yeah, okay. Let's balloon first a little bit. Let's pull the sheath out,
Yeah.
press with the finger. Yeah, it will take us some time here now to prepare the artery with our balloons. Not sure. Can we actually maybe show later a little bit more? Or?
Yeah, it's a good suggestion, sure. I think we have here
Yeah.
a few more talks. Probably do like maybe 2 talks and come back. Is that
Yeah?
enough time for you?
Because
So, Andre, we are back.
Yes, thank you. We are still working, of course, here on that lesion. Just a moment. Need to inflate here that DCB, this the Stellarex 2.580. Yeah, a little 380. He feels it. Yeah. We have quite some spasm currently. Just a moment. So we ballooned everything with the angioscore. Yeah, angioscope here. Already some flow, but distal complete spasm still. Some patients, they react with a lot of spasm to retrograde puncture, also to compression with the finger. We had good back bleeding when we took the sheath out, so I'm convinced nothing is wrong here. We also gave some nitro. However, patient dropped with his blood pressure quite significantly. So therefore, of course, if you see this, you want to repeat it, giving nitros, but we have to be a little bit cautious. So currently, we wait until the spasm resolves, and we started in this case using drug-coated balloons from proximal down to distal. 550, now 3, and next will be 2.580. Okay, yeah, that's what we can show you so far. Maybe we have a chance to show the result later.
Sure, Andre. What about the possibility to
Yeah.
go through the spasm with
To
a
the?
small balloon and to dilate with low pressure?
Our experience makes it sometimes worse. You may induce, again, more spasm. So if I see such a spasm, I also rather pull the balloon out, the wire out, and this is, I think, the best thing you can do to make it resolve as soon as possible. as you can see, we pulled the wire back, it was already in the foot. Yeah, of course, I mean, if it doesn't resolve at all, you may go down with a balloon and see what's going on, maybe dissection. But it's so rare that we do this.
How long do you have to wait normally for such a dissolution of such a spasm?
One more?
Ich wollte noch, ja, oder? Well, it can, I mean, usually some few minutes. However, sometimes it can really be long, 15 minutes, 20 minutes. I can remember a case where we had, I mean, even after an hour, no flow. And next day, everything was open again. So it is really different from one patient to the other. And surprisingly, also sometimes in very calcified lesions, you can see quite some spasm. So I can try to give a shot now, see whether we have flow now already. Nochmal das Bein ganz ruhig halten, bitte. No flow yet.
But this is getting better.
This is already open, but I think just where we ballooned, we now have spasm. Yeah, that's really curious, yeah. So as you can see, it's slowly resolving.
Is your wire back in the true lumen distally?
It was back in the true lumen distally, but because of that spasm, we pulled it out again, yeah.
So, but on this angiogram, the wire isn't at the level of the ankle, or it's back?
We pulled it back.
And we pulled it back. I can show you just a moment.
Okay.
Wire is now back, not completely, but
so,
yeah, I mean,
so
due to this spasm, you may
it looks
even
like
pull
you're
it
in the
higher.
reconstituted segment.
Yeah, correct. So you mean I could pull it even higher up?
No, I would say
correct.
go dist. I personally would go distally and place it in the plantar vessels. And to Giancarlo's point, I would probably take a very, very long balloon, a 2 millimeter balloon, and balloon the entire segment to reduce the spasm.
Yeah. No, too late. I pulled it back.
Okay.
No, we actually
Just a
take the
thought.
wire out of this spasm, completely up. Yeah.
You lost the
And
chance.
now it's really out. Was ist das? Ja, ich glaube, den brauchen wir erstmal. Yeah. No, I think we'll find back in here. I think the artery was here open again. I mean, the problem here was just to find the entrance in the posterior. We'll not pull the wire now out of the entrance, but I pulled it completely out that spasm area. And we just have to wait now, I think. But again, it can really take quite some time.
So Andre, what does the result look like above in the TP trunk, which was the area that will look most diseased, and there was bad dissection before? Could you talk a little bit about how you decide when a flow-limiting dissection is significant enough in the infrapopliteal circulation that you would consider placing a scaffold? Or in your experience, whether you found that for certain dissections, the DCB actually heals very, very well here, and that a scaffold is not necessary.
Yeah, I personally think this is not infrequently the problem. I mean, you see in such an artery which is not really calcified, not so many dissections. Well, maybe if you see them, they may be in a kind of bifurcation area, as maybe here in this case, where you're not sure whether you should implant a tack. Or you see dissections in severely calcified areas, where, of course, the tack does not have that radial force for this kind of lesions. So at the end, I mean, we carefully select these dissections. But we do it on an angiographic basis to decide, not with any wire pressure or whatever. I personally don't find it so easy to decide where to tack or where not.
But I think I agree with you, Andre. Looking at that angiogram, it's not a dissection proximally that's causing the slow flow. It's a spasm.
Agreed. No, but I was looking at the origin of the posterior tibial artery, whether there's a dissection flap there, and whether or not that if you're dealing with a patient with critical limb ischemia, whether you'd feel better getting the patient off the table with that tacked up, whether using a tack or a stent, whatever your preference is based on the way that it looks angiographically.
So, Andre, do you think that we should wait with you, or we can go ahead with the next presentation?
No. No. yeah, please, thank you. We'll take some time. I gave some more nitro, so if you have another presentation, would be nice. Thank you.
Why you don't use calcium antagonist?
Yeah, we don't use them so frequently. Well, my experience is that actually nitro usually works. You mean with the low pressure here, but now he's actually fine again with his pressure. 155 systolic, so I gave some nitro. Yes, thank you, Giancarlo. Yes, I think we are finished for today. So you can see here once again. So I went once again in selectively with the catheter and gave some nitro directly in here. I think it's really the typical appearance of spasm. This several areas where the artery gets reacts with spasm. Thereafter, once again, a shot from above, and you can see here now a very nice flow actually down the posterior tibial artery. And also distal, I mean, the flow is now really nice. Still spasm there, still not completely resolved, but clearly much, much better now. Yeah, so quite happy with this result. Looking for dissections here, I think not really any. I did another angulation proximally here, but also here. So again, what do you think? Any place for tech or?
I think that flow looks beautiful and no major dissection. I think it looks fantastic.
I suppose this is a very impressive result, and I suppose that each ulterior manipulation may provoke a disaster.
Yeah, Andre,
be very happy.
Yes.
Very nice procedure.
Excellent result,
Thank you.
Andre. Very
Thanks.
nice.
Thank you.